Here's a sonohysterogram where we actually filled a small cavity. At the beginning of the examination, there was no cystic change here at all. And as we introduced some fluid, eventually this area filled out. So this is a filling of this, there are cracks, so-called cracks in the myometrium, which were coined in an article that we had in 2009 showing that there are connections from the endometrium filling into these spaces. Also notice there are other changes of adenomyosis, thickened wall, shadowing from thin shadows emanating from the myometrium. The focal form of adenomyosis is an adenomyoma, which is this nodular aggregate of abnormality of adenomyosis. These should be differentiated from leiomyomas. They have ill-defined borders. They lack edge shadows because they're actually just abnormal tissue. They can be elliptical. They have very minimal mass effect. They do not calcify, and they have vessels coursing through them. That is in contrast to the myoma, which forms in the myometrium and pushes the normal myometrium around it. So I've contrasted this for you here. This is the features of adenomyomas, and here's a feature of leiomyomas. So the adenomyoma has poorly defined margins because it just blends with the myometrium, whereas the fibroid is rounded and has borders. The adenomyoma has mixed echogenicities, sometimes hard to even define it in the myometrium, whereas the leiomyoma can be hypoechoic to the myometrium, could be iso, could be hyperechoic. The adenomyoma has cystic areas, small cystic areas. Typically fibroids do not unless there's some degeneration. Vessels course through the adenomyoma. Vessels are displaced around a fibroid, which pushes them out to the periphery. No shadowing except for these thin shadows once in a while, whereas fibroids have much more shadowing. The adenomyoma is tender. When you push with the uterus, fibroids tend not to be tender unless they've bled into themselves or become degenerated or become super infected. All right, so now comes another very large area of myometrial sonography, and that is leiomyomata. Fibroids, myomas, myomata, those are the different words that we use, and we intermix them constantly. I think everybody pretty much knows the typical sonographic features of a fibroid. It's a round mass, heterogeneous, usually hypoechoic relative to myometrium. It tends to attenuate sound to the point of shadowing. It deforms the contour of the uterus, here in this case, lumpy, bumpy contour. Often they calcify, and usually they are multiple. Think of it as misery loves company. Well, when we describe this, we should actually try to pay more attention to describing the location of these myomas. It is very helpful for the clinician to know the precise location so that they can plan their surgery. So we should be using more precise terminology. Most fibroids start out intramural, of course, and a fibroid can be completely intramural. If the fibroid gets very large and abuts the mucosa and serosa, then it's a transmural fibroid with a small submucosal and subserosal component. That's important for the clinician because if you describe it that way, they know they're not going to be able to get this out hysteroscopically nor laparoscopically. They're probably going to have to do laparotomy to go in, remove it, and sew up the hole, or else there could be a uterine perforation if pregnancy forms, etc. Or they may try other methods of treatment. Submucous myomas can be so much covered by the mucosa that they can be completely intracavitary and polypoid. They look like a polyp, and they can be called pedunculated. They can be on a stalk. When you have pedunculated, there has to be a stalk there. So we would like to describe it. In this case, we should say that this is a fibroid which is over 50% submucosal, and the rest of it is intramural. And then if you tell the clinician there's a centimeter or 1.3 centimeter myometrial covering, then they know precisely they can go in hysteroscopically and take this out. If you describe a fibroid such as this one that has less than 50% submucosal component, but only has a very thin couple millimeter covering of myometrium, they will think twice about removing this hysteroscopically because the rate of perforation here would be quite high. They may want to use ultrasound during the procedure or may attempt something else, another therapy. Here are subserosal fibroids. So here's a fibroid that is more than 50% subserosal. The physician, then the gynecologist, will attempt this laparoscopically. It will not do hysteroscopic removal. And we can have a subserosal fibroid. It's covered with serosa on a pedicle, on a stalk, so that's a pedunculated myoma. It's interesting that there can be cervical myomas. There have been vaginal leiomyomas described, tubal leiomyomas, and that's actually not surprising because these originate from smooth muscle. So wherever you have smooth muscle, that's where you can have a leiomyoma. Let's look at some of these sonographically. So here we have a myoma that is predominantly intramural with a less than 50% submucosal component. And I would tell the clinician that there's a good centimeter of myoma around the periphery. And they can then plan the resection. Here is a fibroid that is more than 50% subserosal. And the distance, I could tell them the distance to the endometrial cavity, which is very reassuring. They would go in this and do this fibroid laparoscopically. Here's a myoma. It's intramural. It just abuts the endometrium. It really does not protrude into the cavity, and it has about a centimeter of myometrium covering it. So this is an intramural leiomyoma. Here is a transmural. This is a transabdominal scan showing this uterus with this large fibroid that extends from serosa with a small submucosal component. So this is a transmural. Such a fibroid will not be removed laparoscopically nor hysteroscopically. When there are multiple myomas and the uterus is enlarged, this may be a candidate for uterine artery embolization, or if the woman is trying to preserve her fertility, so this may not be an operative approach at all. Here's a submucous myoma, or submucosal myoma, sometimes called. This is a myoma that is half or 50% submucosal and 50% intramural with a covering of myometrium. This was a patient who had had 3 spontaneous abortions. And once this was removed, she eventually became pregnant. So this was removed hysteroscopically. Now, sometimes you can't tell. There's a fibroid here. It's difficult to tell how much of it is really in the cavity. Is it in the cavity at all, or is it just displacing the cavity? And in that case, one wonders, is it maybe completely in the cavity? The cavity comes here, and then it splits, and then the myoma's in the cavity? Or is it one of these that just pushes the endometrium and is intramural? So a great way to look at this is to do a sonohysterogram. Put a little bit of fluid in the cavity, and there you have fluid surrounding it. This was one of these, a completely intracavitary myoma. Very useful information. Another patient, this is a postmenopausal woman who had had some bleeding, and she has this myoma. She had bigger fibroids during her life, but they were shrinking. And here's the endometrial cavity. So the question is this submucosal? How much of it is submucosal? How much of it is really intramural? What can they do about this? Sonohysterogram helps us. Fluid delineates the cavity, and the myoma is seen to be completely transmural and with no submucosal component. So endometrium is cleared, and this patient's myoma is hopefully going to regress some more. Another one here, what is the submucosal intramural component? The sonohysterogram shows that about half of it is submucosal and the other half is intramural, and there is a good thick covering of myometrium. So this could be removed hysteroscopically.